Thank you, and I thank the organizers for giving me this opportunity. So there are many abstracts which were published, and there are many good abstracts which are published, and we can obviously not discuss all the beautiful abstracts. So I'll be presenting certain highlights from each of the topics which were really good in the respective topics. I'll be discussing geriatrics, mucusitis, neutropenic fever, side effect reduction, and survivorship issues. So coming to the geriatrics, the first topic is really good was risk factors associated with decline in cognitive function in elderly oncology patients receiving chemotherapy. It was published by Upney and colleagues. So this was to evaluate the inter-individual differences in the cognitive function in older patients and to determine which demographic, clinical, and symptom characteristics and level of physical dysfunction were associated with initial levels and trajectory of cognitive function. So what was used for assessment was Montreal Cognitive Assessment and the trial making test. And the assessment was done at 1, 3, 6, 9, and 12 months of starting therapy. The results from the Montreal assessments was that at the baseline, older age and lower levels of education were associated with versus scores. And as therapy was continued, loss of appetite was an important factor, which was associated with decline in the scores. And when we come to the trial making test, at the baseline, older age, living alone, and lower levels of education were associated with lower scores. The conclusion was that there was significant inter-individual variations in the cognitive functions, and the clinicians need to assess the TMT score at the baseline and also need to have a look at the nutritional status. So, in my for a take-home message from this trial that so all elderly patients are not same. So we need to treat each of them individually and differently. We need to assess with some form of scores at the baseline and make sure that what is missing and try to support them compared to the normal individuals. The second part is to discuss the mucusitis. So this was to see whether addition of cocaine mouthwash, 0.5%, would improve the mucusitis in head and neck cancer patients receiving chemoradiation. It was published by Grover and his colleagues. So it was a single center sequential cohort study. That is, initially they received the standard of care management, and when they became symptomatic, cocaine mouthwash was introduced. And the clinical assessment was with visual analog scale, weight, entry tube requirement, hospitalization rates, and questionnaires with ER, PCQLC, C30, and HM35. And these were done equally during the treatment and 1 month and 3 months post completion of therapy. And there were 129 patients, and they could not see any difference with the addition of the cocaine mouthwash. So there is no benefit with addition of cocaine mouthwash. And my take-home message is that we find it very difficult to manage chemoradiation patients, especially in the 4th and 5th week or 6th week of the treatment. There are multiple methods like Benjamin mouthwashes and other methods, but nothing significantly works or it has minimal benefit. There are multiple modalities which have been tried, but as of now, cocaine mouthwash does not have any benefit. And coming to the second part, where similar patients, EC18 was tried. It's a phase 2 randomized double-blind trial to alter the severity and course of oral mucusitis and patients receiving chemoradiation. And EC18 is an oral immunomodulator that minimizes the excessive innate immune response. That is, the innate response to the mucosal barrier is what is modulated. And it was assessed for safety, tolerability, and efficacy. This abstract does not report the safety, but reports other things. There are 105 patients, and there was a initial independent safety monitoring review board, and they could finally decide that 2000 mg was the dose of which EC18 could be used. And the oral mucusitis was assigned, grade was measured twice weekly during the radiation, and weekly up to 6 weeks post the radiation. IMRT was used, and the primary efficacy was the severe oral mucositis in the per protocol population. So results, the adverse events because of the drug were not significant. There's no specific adverse events, whereas the EC18 decreased the period of severe mucositis 0 versus 13.5 days, and the incidence of severe mucositis and the opioid use and the duration. So this is something just very new because we know that none of these measures actually have a great impact on the mucositis. So if we could reduce the incidence of severe mucositis, that would be great. But we don't have the long-term safety data as of now. We know that we could probably potentially reduce the incidence of severe mucositis. So coming to the fourth topic, all these is what everybody is very interested and what we are really proud of. It's a randomized controlled trial of neutropenic diet versus regular diet in patients undergoing induction chemotherapy for acute leukemia. It was done from the Cancer Institute, Chennai. Yeah. So we all think and believe that probably giving neutropenic diet during acute leukemia would probably decrease infections, but always there has been a controversial evidence. So this was a randomized trial, which we really are proud being an Indian. And patients between age 1 to 60 were treated as per the guidelines and were randomized to normal neutropenic diet or regular diet. And the primary objective was to compare the incidence of major infections, the pneumonia, blood culture positivity, pleural neutropenia between the two diets. And the secondary objective was to compare the minor infections, stool, microbial flora, and the mortality rate. It's a standard. So standard comparison, whether any major infections. 102 patients in the neutropenic diet arm and 96 patients in the regular diet. And there was no major differences in the major infections, blood culture positivity, inotropic support, mechanical ventilation, on all other parameters. What was assessed, there's no significant difference between the two diets. So it did conclude with a very significant evidence and information that probably we need not give neutropenic diet. Probably it is a stool microflora, what the patient has probably causes the infection, and what not the diet what we give. Coming to the next topic, scalp cooling. This was the study itself explains the conclusion. No negative influence of scalp cooling on the survival of breast cancer patients, so it's self-explanatory. But we all know that scalp cooling can reduce the incidence of alopecia, at least in certain chemotherapy agents. But we always had a concern that there could be some incidence of scalp metastasis, that could be some probably increased recurrence rates. So this study was to compare the efficacy and safety of scalp cooling in a large groups with extensive follow-up by comparing overall survival between the female cancer patients with or without scalp cooling. The patients were selected from databases. One is the Netherlands Cancer Registry for non-scalp cooling and Dutch scalp cooling registry for scalp cooling patients. And the OS was according to scalp cooling was calculated using the Kaplan-Meier analysis and the univariate Fox regression model. So there are 1,229 patients non-scalp cooling and 466 in scalp cooling. And what it showed that there is no difference in the overall survival between the two groups. So that need not be a concern for using scalp cooling whenever it is feasible. There are other technical problems might be there for using scalp cooling. As such, we need not worry about the overall survival or the disease-free survival. That is what it concludes. The next topic for survival, supportive care. So this is for supportive care for cancer patients in low and middle income countries. And so it's a review of literature by Dr. Kannan et al. So though there is extensive data on supportive care, but actual instance of cancer has always been in the lower and middle income countries, and we have a lack of literature in these areas. So this was a study to describe the scope of supportive care intervention implemented for patients for cancer patients in the low and middle income countries, which constitute more than 70 to 80% of all the cancer patients. So it was a systematic search using the PubMed, ERIC, Sinhal, and the Cycling. And the original research studies which focused on low middle income countries and studies that implemented any type of supportive care service or program for adult patients were included. There were 36 studies representing Asia, Middle East, and Africa. And what we could see is most were reported on the woman cancer and included interventions for health literacy, psychosocial support, symptom management, and peer support. We don't have further information on how it was done, but what we could conclude is that in LMICs, which actually constitute the heaviest burden of cancer, there is a lack of gaps in providing research, evaluation of supportive care, and delivery of supportive care as well. Coming to the next topic, which is something which is really important. This is for self-care for head and neck cancer patients with lymphedema and fibrosis. It is a pilot randomized clinical trial. So fibrosis and lymphedema is something we are not too worried, at least because most of the head and neck cancer patients, we are only worried about the acute phase and the immediate acute phase. We are not actually too much worried about the late toxicities associated with head and neck cancer. So, and we often see that the neck is very hard and we cannot even palpate the nodes to see the response. So this is very, very common with lymphedema and fibrosis in head and neck cancer patients. It is a debilitating late side effects. Some people have severe stiffness of the neck, and usually during the therapy and immediately therapy, it is usually done by the therapist. And this study randomized patients who were given usual care without any therapy, and randomized the other set of patients to usual care with lymphedema fibrosis therapy. And the other set of patients, along with that, a lymphedema therapist used to follow these patients and provide support and assistance after the therapy as well. So what we could see is that assessments at baseline 3, 6, 9, and 12 months. Assessments were done for lymphedema and edema fibrosis, symptom burden, and jaw range of motions. So patients who are randomized and given assistance and help and information regarding lymphedema fibrosis, they showed significant decrease in the severity, reduction in the symptom burden, and improvement in the jaw range of motions. But even if the patients are taught how to do, they could probably do it. And even if what study shows is that even if lymphedema therapist follows them up, probably that may not be superior to what the patient does at home. So even if the patient could do it post-therapy at home, probably that would be enough and need not follow with the physiotherapist or the lymphedema therapist. So this is very important information. So lymphedema standard of care program is potentially feasible and efficacious and need not be followed by physiotherapist post-treatment. And coming to the last part of the discussion and the abstract presentation. So this is an abstract which looked at sex differences in comorbid conditions, health behaviors, and healthcare utilization among the AYA survivors. It was presented by Choi and his colleagues. We know that AYAs, there are increasing incidence of multiple problems, which we do give importance, but few studies have actually explained whether males and females have different types of problems and whether males had more problems or females had more problems. So this study compared the outcomes between AIs among controls, between the males and females, and between the males and female AIs. So the data was obtained from Texas Behavioral Risk Factors Surveillance System, and AIs between 18 to 39 years at survey completion who had been diagnosed with cancer were matched the controls. So results, there are multiple results, but when compared to the control, AYA were more likely to develop depressive episodes, and they needed to see the doctor more frequently, and they are more likely to smoke, and they had a higher chance of developing arthritis and high blood pressure. And compared to the male AYAs, female AYAs are more likely to develop comorbid condition, arthritis, and poor general health, whereas the male AYAs had a more chance of developing heart disease. So this is contrary to probably what everybody would feel. Probably everybody would thought that male AYAs would have probably had more problems compared to the females, but evidence seems to be a contrary. With that, thank the organizers for giving me the opportunity. I hope I finished on time.